Okay. All right. Hello, everyone, and welcome to our ECOSOC Youth Forum side event session. No rights without access, reproductive health, gender equity, and economic justice. My name is Jessica, and I'm a student at Yale and the founder of Choice for Tomorrow, a youth-led initiative working to expand reproductive rights, access, and leadership.
And I'm Sua Park. I'm also a student at Yale, and I'm the other co-founder of Choice for Tomorrow. Jess and I will be your hosts for today. So this event brings together global health leaders, youth advocates, and UN representatives to discuss one critical truth, that reproductive rights mean nothing without access. So whether we're talking about contraception, menstrual health, abortion care, or economic mobility, we believe that real freedom starts with real access.
Today's event is co-sponsored by the Medical Women's International Association, American Medical Women's Association, the North American Alliance for Health Arts, and Youth Help Youth. We're honored to welcome leaders from around the world who are working across health systems, communities, and policy spaces to make that access possible.
So to begin our event today, we're really excited to welcome Dr. Eleanor Watanabe, who is the president of the MWIA and a global leader in gender equity and reproductive justice. So Dr. Watanabe, the floor is yours.
Thank you so very much, Sue. And I also thank our co-host and co-moderator, Jessica. I bring you warm greetings from the Medical Women's International Association. And we are thrilled, absolutely thrilled, to partner with Choice for Tomorrow at this side event at the 2025 UN ECOSOC Youth Forum. It's great that we are focused on the subject matter, no rights without access, reproductive health, gender equity, and economic justice. Let me tell you a little bit about the Medical Women's International Association. We are an association that has existed since 1919. And for over our 105-year history, we have directed our efforts, our resources, our time, our talent, our treasure towards proactively empowering women in medicine. And we continuously strive to improve the health and well-being of the communities that we serve, with a special focus on women and girls around the world. I commend the convener, the president of ECOSOC, and co-organizers for providing this platform for our cherished youth leaders and delegates to make their voices heard. The triennial theme for the Medical Women's International Association is One Humanity, Health Solutions Through Partnerships. One Humanity speaks for itself. The fact that we are all, first of all, humans, and that we all deserve respect and dignity. Finding health solutions through partnerships is exactly why we are here today, partnering with Choice for Tomorrow. This wonderful student-led coalition working to advance reproductive rights through policy, through advocacy, and grassroots mobilization. So our work is indeed aligned because MWIA's strength lies in our voice of advocacy. We pride ourselves by saying that we are the drumbeat for women's health around policy. And as I've said before, looking also at serving our communities and grassroots mobilization. And that is why this partnership, I see it as mutually reinforcing. We identify also with our youth. We, as MWIA, and I in particular, as the president of MWIA, believe that our youth are not our future. Let me say that again. We believe that our youth are not our future. Our youth are our today. They are our present. And you, our youth, you are our now. For as long as leaders, planners, policymakers continue to call our young people the future, they will continue to leave our young people out of the mainstream and keep them in the stalls and in the sidelines. When we realize that our youth are our today, our present, and our now, they will be right in the center. They will be the focus. And the rest can be on the sidelines cheering them on. Our future are those yet unborn. It is not just enough for us to hear the voices of our young people, of our youth, but we must act promptly and swiftly regarding youth-led recommendations. One of my favorite sayings is that we must leave the ladder. For those of us who have gone before, we must leave the ladder leaning against the wall after we have climbed up to make sure that others can climb after us. Which is why, in order to move the needle regarding the Sustainable Development Goals, I advocate for the AAA goals. What are the AAA goals? Accelerated, actionable, and actualizable goals. So in order for us to attain the Sustainable Development Goals, there must be acceleration. Our interventions must be actionable and they must be actualizable. Now, from the womb to the tomb, when we speak of sexual and reproductive health and rights, we must not limit ourselves to the sum of the reproductive parts, but instead look at the holistic health and rights, including physical, mental, and spiritual, because we are holistic beings and we all have our different lived realities and our vulnerabilities. When we talk about access, it is about removing barriers. And some of the barriers that exist among low and middle income countries are lived realities such as a woman having to seek permission from her husband or from her mother-in-law before she can even begin to think of accessing reproductive health care. That forms the first barrier at the household. So I want us, as we think about the subject matter today, that we must think that access is not the same for everybody. So when we say no rights without access, let's remember that these barriers sometimes exist at household level. And how about gender equity? I would like to make a clarion call for women's health research and to broaden and widen the innovation ecosystem so that we can look at issues that impact women uniquely, differently, and disproportionately, which cause women to have different risk factors, different presentation, and different outcomes. Our title includes economic justice. Again, with the lens of the global society in which we are, I'd like to remind us that when we speak of empowerment, especially economic empowerment for women, we've heard before that you should not just give women fish, but you should teach them to fish. A friend of mine, who I quote constantly, Heather Ibrahim Leathers, says, don't stop at teaching them how to fish. Teach women how to own the lake. Friends, as I conclude, I must bring to your attention the intersection between sexual and reproductive health and rights and violence against women and girls. Wearing my other hat as co-founder of the Every Woman Treaty, we are advocating for a global treaty in the form of an optional protocol to CEDAW. CEDAW is the Convention on the Elimination of Discrimination Against Women and Girls, all forms of discrimination against women and girls. And we are advocating for an optional protocol to CEDAW to end all forms of abuse that hinder sexual and reproductive health and rights. Some of these include early marriage, with the resultant vesicovaginal fistulae, female genital mutilation, and intimate partner violence. These are just opening remarks, but I must give you some exciting news. I would like to invite you to join MWIA at her 33rd International Congress, scheduled to take place in 6 months' time from the 12th to the 14th of October in Cairo, Egypt. I am excited to see online today Dr. Amani Asfour, who is the president-elect of the Medical Women's International Association, soon to take over from me, and she's also the Congress Planning Chair. I will now leave you to our erudite speakers. I recognize those who are members of the Medical Women's International Association. Delighted to have with us our North American Vice President, who is also our United Nations representative, Dr. Connie Newman, as well as our Young MWIA Chair, Ashna Basu, who is up at around 3 a.m. joining us from Australia. Thank you so very much for the opportunity of these opening remarks, and I hand over back to Sue R. and Jessica, our able and capable moderators. Thank you.
Thank you so much, Dr. Watanabe, for opening our space with such vision and urgency. Next, we will be hearing from Dr. Connie Newman, who is the Vice President of the Medical Women's International Association and a physician and reproductive health advocate who has been a fierce champion of global access and women's health. Please join me in welcoming Dr. Newman.
Okay. Thank you very much. I'm trying to share my slides, which are not in full mode.
We can see the slides. We can see them.
Okay, there they are. So anyway, I want to thank Sua and Jessica for giving me this opportunity to speak. Reproductive rights and access to reproductive healthcare services has been something that I've been fighting for many, many years, more than 20 years. So I'm going to be talking a little bit about that. And I'm also going to be talking about how men and women differ in their manifestations of disease, and that this sometimes leads to misdiagnosis in women and delay in treatment. So I want to disclose that, first I said to myself, I have no disclosures, but then I realized I co-edited this book, which is an educational book for physicians, for students, about how sex and gender impact clinical practice. So I thought you needed to know that. It's sort of an advertisement too, because we're now going into our second edition. But I also want to say a word of caution, because I'm going to be speaking about some terrible things that have happened to women, some women, particularly devastating events related to the lack of reproductive rights and the lack of access to healthcare services and sexual education. So what is health equity? Well, health equity doesn't mean that we all are as healthy as each other. It means that everyone can attain their full potential for health and well-being. And there are many things that need to happen for health equity to occur. And of course, two of them are access to reproductive health services, access to reproductive rights, and sex and gender differences in disease to avoid delay, understanding those differences to avoid delay in diagnosis. I want to start out with reproductive health services and rights. I'm going to begin with a story from Ethiopia. This story was written in a book called The Everyday Feminist by Latanya Mapfret, who I met when I was volunteering at Planned Parenthood Global. So this is about a 16-year-old girl in Addis Ababa, Ethiopia. I'm not sure I could pronounce her name correctly, but it is Sige. She was living on the streets because she wanted to support her family who lived in Nairobi. And how did she do this? Well, sometimes she had to beg, sometimes she sold items. She occasionally had consensual sex with men who she thought were her friends, but sometimes she was raped. She met a child protection officer of UNICEF, Yuan. And this woman gave Sege money to return to her village. But when she returned to her village, her mother noticed that she was pregnant. Her mother was horrified. And abortion, of course, was illegal. And culturally, people did not think of adoption in Ethiopia. So Sege decided to go back to Addis Ababa because she didn't want to bring more shame to her family. So the UNICEF worker, Yuan, found this young woman sleeping in a small church center. And she took her to an obstetrician. She took her to her home as well. And the obstetrician found out and told her that her HIV test was positive. But Sege didn't hear that. He also told her, she didn't hear that he said she could have a healthy baby, even though she is HIV positive. She just thought, oh my gosh, I have HIV, I have to do something to stop it. So she left Ewan's home, she went to a convent, and then, pregnant, she began to fast. But she had heard that fasting would cure HIV. 12 days after she stopped eating, Sege and her baby died. And Yuan wondered, and I wonder, if Sege would have survived, if she had received sexual and reproductive health care with the ability for adoption, which was frowned upon in Ethiopia, or abortion. That's my first story. So what are the lessons from this story? Obviously, there's a great need around the world for sexual and reproductive health education. There are cultural differences that I believe Dr. Watanabe referred to, differences in people in different societies. There are many myths about diseases which prevent people from being healthy. And in many places, including in the United States, there's poor access to contraception and to safe and legal abortion. So I firmly believe that to achieve gender equality or gender equity, women must be able to plan their families. And that lack of access to contraception and safe, timely, affordable, and respectful abortion care is a critical public health issue and a human rights issue. The World Health Organization in 2024 published some statistics about abortion, which they believe to be an essential healthcare service. And they said that 60% of all unintended pregnancies end in abortion, and that all pregnancies, 29% ended in abortion. And the astonishing number to me is what's below, that almost half of abortions are unsafe, which is a great danger to the pregnant woman. An unsafe abortion, as you can imagine, is a preventable cause of maternal deaths and morbidities. It can lead to physical and mental health complications and social and financial burdens for communities and health systems. So I'm showing you a picture. I don't know if you can appreciate it, but there are a lot of women, well, a lot of people waving green flags. I'm not sure if anyone knows where this is, but this is in Argentina. And this happened many years ago, starting in about 2015, when a 14-year-old girl in Argentina was beaten to death by her boyfriend because she was pregnant. At that time, abortion was illegal in Argentina. So tens of thousands of women in Argentina began protesting in the streets, and they held up these green scarves which said, ni una menos, not one woman less. This became a viral hashtag and spread throughout South America. And in 2020, this grassroots effort led to the approval of abortion in Argentina. This is a graph or a picture, of the world, of the countries in the world, categorized by their reproductive rights. And this comes from the Center for Reproductive Rights, which is an important organization that has lawyers that help women globally. And you can see that the green areas are places where you can get an abortion on request. Of course, gestational limits vary. Prohibited abortion is in the very red areas, and abortion permissible just to save a person's life is this orange color. And so on. Yellow means you can have an abortion to preserve health. You can see that in Africa. And abortion is legal in some countries because of broad social or economic grounds. But what we see that has changed in the United States is that abortion is no longer available in every state. It depends upon the state. So this is what happened after Roe v. Wade, what we call it Roe, was overturned in 2022. This law, Roe v. Wade, was enabled any woman to ask for an abortion without getting consent from anyone, without even asking consent from the doctor. And this was very disturbing to some people. And there was many Supreme Court cases about this. And in 2022, a case called the Dobbs case ruled that the federal government should not regulate abortion, that the right to have an abortion should go back to the states of the United States. And right away, 12 states had abortion bans, total bans. And another couple of states had very restrictive and restrictive laws. So this changed, which changed everything in my country. And you can see in the purplish colors that these are states that protect abortion, but they don't seem to be as many as the states in orange and red. So now I'm going to tell you about another story about a woman who lived in Texas. She had a child who was maybe 2 years old, and she wanted another baby. So she and her husband planned a pregnancy. And at 17 weeks, she started to bleed and had a miscarriage. So she went to the hospital so they could help her, so they could remove the fetus, but they wouldn't do anything because they heard a fetal heartbeat, even though this pregnancy was not viable. And they felt that if they performed this procedure to help this woman, to do what's right by this woman medically, that would be considered a criminal offense. So they didn't do it right away. And her uterus was exposed to infection. And finally, after she delivered this dead fetus, Jocelyn died of an infection. So what's happening in the United States is that doctors in some states where abortion is criminalized are afraid to treat miscarriages properly. They send women home bleeding. They're also afraid to treat ectopic pregnancies, which can cause death. It's very distressing. So now I'm going to go back in time to 1995 to the Fourth World Conference for Women that was held in Beijing, China. And what happened out of this conference is that they endorsed an agenda for women's rights that is very well known. And about 189 countries were represented there and at least 30,000 activists. And the Beijing Declaration said that there were 12 critical areas of concern for women, and one of them was health. They also said that there are many challenges facing women in terms of their health, that most women cannot achieve good health and well-being. They said that women's health is affected by unequal access to healthcare resources for the prevention and treatment of disease. They noted that in the health system, there was gender bias usually against women, and that women were provided inadequate and inappropriate medical services. But the last point on this slide really interested me because they acknowledged in 1995 that women are affected by many of the same health conditions as men. They have the same diseases, but women experience them differently. And this is something that many people, many doctors still do not know, and I think it's important to educate them. So in 1946, the Commission on the Status of Women, called CSW, was founded. It's an intergovernmental body, and it's dedicated to promote gender equality, women's rights, girls' rights, and to empower women. And they're responsible for reviewing the progress and implementing the Beijing Declaration. Recently, last March, just a month ago, CSW had about a 2-week meeting to review implementation of the Beijing platform 30 years later, like what had been achieved and what needed to be done and what the challenges were. And of course, MWIA, we were represented at that meeting, and we spoke about this topic, and basically delivered a program which indicated that much more work needs to be done in women's health. And I'm going to turn to sex and gender differences in disease. So how do I define sex? Well, sex is a biological variable. It refers to biological differences based on sex chromosomes and their expression, and also based on hormones secreted by reproductive organisms. And we now know, but not every doctor knows, that sex differences affect disease epidemiology, pathophysiology, presentation, and efficacy and safety of therapies. And this is one of the topics that I advocate for. Gender, however, is a sociocultural variable. It refers to socially constructed and enacted roles and behaviors which occur in historical, social, and cultural contexts. Gender is non-binary and can shift with time in a person. So gender can influence the behaviors of patients and also of their healthcare providers, and it can influence their access to healthcare. Healthcare access is difficult for women because many women don't have the money to get healthcare, and many women are burdened with childcare. Men, however, who actually can afford to have healthcare are less likely to use it. Prescribing practices are biased against women. There are medicines that can prevent cardiovascular disease, prevent heart attacks and stroke. These are statins and antihypertensive medicines, and studies have found that these medicines are less often prescribed to women. And we all know, I think many of us probably know, that women experience myocardial infarction, the symptoms of it, differently than men, which leads, and also physicians don't believe that young women can have heart attacks. And this leads to misdiagnosis and delay in treatment. So I've been talking about biological sex and gender, but there are many other factors that contribute to health. They're listed here: age, geography, food, housing, ethnicity, race, climate, and government, social policies, and societal values. And health equity can be achieved when everyone can attain their full potential for health and well-being. This is a goal, but it seems like we're not very close to it. So the book that I co-edited with Dr. Marjorie Jenkins talked about misconceptions that people have. They think that breast cancer is only a women's disease, but men do get breast cancer. They think that the symptoms of lung cancer are similar in men and women. That's not true. They don't think women get COPD, but it's much more common. It's happening much more in women. They also believe that men may not be victims of domestic violence, which is a myth. And unfortunately, many practitioners believe that young women do not develop heart disease. So this is a picture of a man clutching his chest, and I'm presuming that he's having a heart attack due to atherosclerosis in his coronary vessels. So the question I have is, would a woman with a heart attack present like this? So basically, the answer to that is she might, but she might not, because women often have different symptoms than men. They do have chest pain. Many women present with chest pain, but they sometimes have shortness of breath without chest pain and nausea and vomiting. And doctors think that they have a gastrointestinal illness and do not recognize that they are having a heart attack. So another question that I'm posing is which patients with symptoms of coronary ischemia, meaning loss of blood flow in the coronary vessels, which patient will be taken to the hospital more rapidly, a woman or a man? Well, I think we all know that it would be a man. Heart disease is not often recognized in women. There's a delay in transport to the hospital, and there's misdiagnosis, as I explained before. This is a figure from the textbook that I co-edited with Dr. Jenkins, and it shows sex differences in coronary arteries, and it may explain why the pathophysiology of cardiovascular disease differs in men and women. So on the top, we see a normal artery. There's very little plaque. It's the yellow stuff on the outside. In the middle, we see a coronary artery of a woman. And we do see atherosclerotic plaque, but we also see that the blood can flow. There are no obstructions. But in the bottom picture of a man, we can see that there is a place where the blood cannot flow. There is an obstruction. So we've learned that women have less obstructive cardiovascular disease than men. They also have more coronary artery reactivity. So there are differences in coronary disease that may influence the symptoms that women have. There are also sex and gender differences in cardiovascular disease risk factors. For example, preeclampsia is associated with increased atherosclerotic cardiovascular disease throughout life, and gestational diabetes increases the risk of diabetes 7-fold, but it also increases the risk of MI by at least 4-fold and stroke by 2-fold. Another disease that differs in men and women, there are many, but I'm just giving you a few examples, is systemic lupus erythematosus. Because 80% of autoimmune diseases occur in women, so some healthcare providers do not believe that a man could have SLE. So men are diagnosed later, and when they're diagnosed, they have more systemic illness. They have more chest pain, more severe kidney disease, and more neurological symptoms. Health equity is essential for gender equality. That is a statement that we've talked about at some of the MWIA programs that we had surrounding the UN meetings. And in this year, MWIA wrote a statement to the Commission on the Status of Women, which is published on the UN website. And this is what it talks about. To achieve gender equality, women and girls throughout their lifespan must have access to evidence-based and women-focused healthcare. That's pretty important. Our state talks about some of the challenges to health equity. They're listed here. There's bias, attitudes towards women and certain diseases lead to inappropriate diagnosis and delayed treatment, as I explained. There's a lack of recognition by healthcare providers of sex and gender differences in diseases. There's poor access to healthcare for women due to caring for the family, not having enough money, and not having enough clinics in the country. There's limited access to contraception, especially in remote areas. And there are national laws that ban abortion or severely restrict abortion, even in cases of rape, incest, and threat to the mother's life. And of course, there's much violence against women, which causes poor physical health and poor mental health. Our recommendations in this statement that we wrote in 2025 recently are that we need education of healthcare professionals, including students, on the differences in disease between men and women and the adverse things that happen when these differences are not recognized. We need government policies to commit to financial support to increase the capacity of the healthcare system. We need to educate healthcare providers and the community, and we need money to do that. And we need intervention programs to empower women economically. In order to achieve gender equity in healthcare, we need to partner with other stakeholders. That's very important. Our other set of recommendations was about research. We do not have enough research in women to really understand disease in women. So we advocate for funding for research in women and men with data in women and men disaggregated and analyzed by biological sex. We also advocate, when feasible, to include variables in studies such as ethnicity, geographical location, age, socioeconomic status, and perhaps that data can be analyzed as well if we have enough of that data. And in this recommendation, we addressed artificial intelligence because there is a fear that there will be algorithms developed from artificial intelligence, algorithms to diagnose diseases. But if they're only based on data in men, they will not be able to help women. So we need data in both men and women. So I'm closing my talk now, and I hope that you understand from what I've said that health equity is essential for gender equality. Education and research about sex and gender differences in disease and its management, and behaviors of patients and doctors towards disease and treatment are critical for achieving health equity. And advocacy is important. Advocacy locally, nationally, and globally will hopefully improve access to reproductive health care, including contraception, and importantly, including safe and legal abortion. So in closing my talk, and I want to acknowledge people who have made an important difference in my life. I acknowledge Planned Parenthood in Northern, Central, and Southern New Jersey, where I served as board chair for the last 4 years, Planned Parenthood Global, and of course, the Medical Women's International Association. And the people I want to thank are Dr. Eleanor Watanabe for allowing me to do advocacy through MWIA. I want to thank Latanya Mabfret, who I met at Planned Parenthood Global. And I want to thank the late Cecile Richards, who died a few months ago of brain cancer. Here's a picture of me with some other people in Kenya, and next to me is Cecile Richards. This was some years ago. And I must say that she was my role model for advocacy. She was an incredible woman. Next to Cecile is a man who was an obstetrician. This particular man was put in prison for 1 year because of an abortion that he performed, but actually he told me that he did not perform that abortion, but he and his nurse were in prison for 1 year. And on top, there's a picture of a pediatrician who was my father, Dr. Samuel Baum. And I want to say that he encouraged me to become a doctor. And he taught me a lot about patients and about patient care. And I learned more from him sometimes than I learned from some of my professors in medical school. And my father believed that women should become doctors. And he also believed that women could become great doctors. So I want to thank all these people and these organizations. And I want to thank you for listening to my presentation. I can stop sharing. And I'd be happy to take some questions. Oh, Amani's clapping. Thank you.
Thank you so much, Dr. Newman, for this beautiful presentation. I'm sure, given your decades of experiences, you've collected so many stories. I wonder, how do you keep track of all of these experiences that you've seen throughout the decades that you're able to just be able to integrate them into your presentations like this? Like, do you keep like a journal to yourself, like when you see something that particularly touches you? Because as a physician, I'm sure you have so many stories.
Well, I have a lot of stories from the Planned Parenthood healthcare facilities that I volunteered in, as being chair of the board, and we have records of those stories. What we've been able to do in our Planned Parenthood is to give access to abortion to women who cannot get it in their states. We have built a new health center. We have facilitated We have increased abortion services in several of our health centers, and we are seeing more patients than ever before. So I get some stories from my Planned Parenthood colleagues, but also I'm very interested in this topic. I'm interested in global reproductive rights. So I research these stories on the internet, and when I see something, I keep a record of it. Particularly, I read The Everyday Feminist cover to cover, and that's how I found the story about this poor girl in Ethiopia. Thank you for that question.
Thank you for sharing. I also have another question, but I don't want to take up space if someone else wanted to jump in. In that case, I'll like to ask something else if you wouldn't mind.
Sure.
Dr. Newman, I really admire how, like, as a physician, you're able to amplify your impact on the global stage by joining all of these roles. So when you first started as a doctor, did you know that you would become this kind of like advocacy on the global stage? Like what was your journey from like medical school to a practicing physician to now like becoming a voice for gender equity like this?
Well, I never thought that I would be doing this. I knew about social determinants of health. I knew about discrimination against various people. But when I was a young doctor, I was an academic, I was doing research, and I had 2 children, and I was extremely busy with my work and caring for the family. But I knew that there was injustice, and I knew there was reproductive injustice and there was violence against women. And only in my later career was I able to focus on advocacy. But I think, looking back, I think I could have done something earlier than that, but it took me a while. Thank you.
Thank you. You are a role model to all of us. Thank you so much for your beautiful presentation and for grounding us in the complexities and the possibilities of what true health equity can look like. From gender to geography, policy to lived experiences, you've set the stage for a conversation we're so excited to keep building. So thank you, Dr. Newman. And now let's meet our panelists and hear how they're pushing this work forward in real time. We're joined by 4 incredible leaders working across medicine, policy, advocacy, and research. So before we jump into the questions, I would love for each panelist to begin by briefly introducing themselves, and then we'll dive into the discussions.
I can start if you want, and then I can pass it on to the next person. Great. Hi, so my name is Megan Lishka. I'm a lecturer here at Yale University. I am a historian by training, and so I would say generally historians are good at identifying problems and explaining them, and are not always so good at solving those problems and doing advocacy in the world in that way. So I would say I see one of my core roles in this is through education. I teach a lot of pre-meds, I teach medical students, and really trying to get them to think about health equity and justice frameworks. My own research looks at anti-abortion activism in the US and Canada, and specifically the ways that these movements use health spaces, health language, science to make political claims. So even though my work is pretty US or North America focused, I think looking to the past and understanding how colonial narratives have shaped where we are today, and then looking right now and thinking about the way that the current administration is leveraging things like foreign aid and foreign policy to shape both domestic and international politics. I think there are a lot of connections we can make between the historical work that I do and the kinds of advocacy work that is so essential on the ground. So I'll leave that there, but I look forward to talking more very soon.
I'm happy to go next. My name's Ashna. Ashna Basu. I'm a doctor based in Sydney, Australia. So I'm sipping my coffee because it's 4 a.m. here. I'm so excited to be here with all of you. I'm the chair of the young branch of the Medical Women's International Association. So you heard a lot from our amazing president, Dr. Watanabe, about the work MWIA does. Young MWIA is the branch that represents medical students and doctors that are under the age of 40 globally. And we reach to all corners of the world. We've got America, Mauritania, Nigeria, Ghana, Australia, Sweden, like countless connections everywhere. And our goal is to mobilize this incredible community of young medical women, looking at offering professional development and educational opportunities, providing a safe space for young medical women to debrief and talk about the issues that's affecting them, but also our kind of common pursuit for equality and health for women and people of all gender diversities around the world, and how we can work with our member organizations and harness the power of young medical women to achieve that. I'd also quickly like to acknowledge, I appreciate this isn't a custom in other countries, but I'm in Australia, and here we like to acknowledge the traditional custodians of the land on which we meet. So the First Nations people who are the traditional custodians of the land I'm on, are the Bedegal people of the Eora Nation. I'd like to pay my respects to any First Nations or Indigenous people that are here with us today and acknowledge our elders as well. Thanks.
Okay, I can go next. Hi, everyone. My name is Marija Broekhuizen. I'm a water, sanitation, and hygiene specialist, and I work with UNICEF headquarters based in New York. And I've been working with UNICEF for the last 12 years in different countries. I started my career in Ethiopia. So the story that I heard from Dr. Newman was very compelling and very inspiring for me. I've seen Ethiopia in 2012, and I have vivid memories of the life there for girls like her. I started my career in water, sanitation, hygiene, but also worked on menstrual health and hygiene and washed in schools. And I continued working in South Sudan in the war there. So I did emergency work and then moved to Yemen, where I worked in also in the wash sector and emergency preparedness and response. Then I moved with UNICEF to India, where I worked more on the development work again in WASH. So I've worked throughout most of my career in WASH, water, sanitation, hygiene, but always worked with adolescent girls and boys, women, looking at gender aspects, health aspects, and menstrual health. Here in UNICEF in headquarters, I lead the global menstrual health and hygiene agenda, where I provide technical assistance for our country offices and also work on global advocacy, global monitoring, data analysis, evidence generation. And yeah, just a little bit about UNICEF. UNICEF is the United Nations Children's Fund, and we work across different areas, including education, health, nutrition, water, sanitation, hygiene, social protection, social policy, child protection. And so menstrual health is an integral part of our program, which we implement in around 80 countries. Well, that's it. Thank you.
Okay, lady first, so maybe I'm the last one. Okay, I'm Steven from China. For the past 13 years, I've been working as a trainer in SIHR in different provinces in China. And in 2012, I founded a team of university youth volunteers with help of China Family Planning Association and the UNFPA. It's called Hangzhou Youth Network, which serves a diverse range of people from primary school students to university students, parents, teachers, and medical workers, and so on. And after my graduation, I worked in a hospital, and now I work in Zhejiang University of Finance and Economics, which can also better carry out sex education for college students and sport students to carry out peer education. Yeah. So today is a really big challenge for me. It's about 2 a.m. in China. And it's the latest conference I've ever attended. But I think hearing the male perspective in such a meeting held by MWIA is also a sign of SDG 5 gender equality. So thank you very much for invitation and looking forward to sharing more information with you. Okay.
Thank you so much for this introduction from our wonderful panel. So grateful to have you here, including people who are working across time differences. I'd like to direct my first question to Dr. Basu. I know you're a doctor in psychiatry, so I would like to ask, in your experience, how does the stigma surrounding mental health intersect with reproductive health challenges, and what strategies can healthcare providers employ to address both?
Thanks for a great question. So the reality is that a lot of the same, like there is a huge area of overlap because a lot of the same issues contribute to both, and both areas tend to be stigmatized and can also at times be weaponized as tools of kind of institutional or colonial or patriarchal violence against women and gender minorities as well. So there's a few kind of levels. So at the social cultural level, we can think about things like silence and shame from external sources existing. So the pressure, the taboo and the pressure not to talk about things like miscarriage, abortion, and infertility. And thinking about that same pressure not to talk about mental health conditions, whether it's the fact that you're struggling, that you're a victim of trauma and you've got PTSD symptoms, or kind of the taboo around recognizing that people live with psychosis. And recognizing as well that there are a lot of overlaps and there's an area of intersection in the conditions as well biologically. So if you have suffered pregnancy loss, or you're struggling with infertility, or you've required access to an abortion that's been traumatic, or that you've not been able to get access to that abortion, or that you've been a victim of sexual violence, all of those things are more likely to result in poorer mental health outcomes. So it's a vicious cycle. And then again, at that social level, the same things that are barriers to access to reproductive healthcare are often barriers to access to mental health care as well. So things like your financial situation, your geographical situation, your level of education, the services in your area. There are issues unique to both. For example, for people that are gender diverse. So if you're a person with a uterus that's experiencing issues related to those biological organs, you're also more likely to have struggles with your mental health as well, and that overlaps. Trauma is a huge risk factor, and we know that gender-based violence has an impact on access to reproductive care and reproductive health, and also to mental health. So you can see that like the Venn diagram is looking a lot like a circle. Then at like a psychological level, I often think when I'm seeing patients about the grief and the loss that comes with this journey, particularly when it is so taboo. So navigating the psychological impacts of losing a pregnancy, or being forced to carry a pregnancy to term, or the trauma of engaging with that healthcare system. And not only is that external taboo and blame, but there's also a sense of internalized shame and guilt that can come with that as a result of societal pressures. And then, I spoke about the biological vulnerability and overlap, but that also, we also need to think about hormones. And so the hormones you're getting during IVF, hormonal fluctuations during the perinatal and menstrual period is associated with, something like a postnatal psychosis, postnatal depression, postnatal anxiety. But also we know increasingly, and there's chapters on this in Connie's fantastic book, that there are gender-based differences in mental health, and that can be seen in things like schizophrenia. It can be seen in around the kind of menstrual period and menopause. Are there things that we're misdiagnosing as menopause that are actually kind of cognitive and emotional, misdiagnosing as mental health issues that are cognitive and emotional symptoms of menopause? So they're both areas that are historically underfunded, that are under-researched, that deeply intersect with each other. And then in terms of thinking about ways to address that, one huge way is reciprocal education. So clinicians and, community organizers, peer support workers, or working in both spaces, advocates, policy people, knowing about the fact that this kind of bidirectional relationship exists and these intersectional relationships exist is huge. So that's things like if you're a provider of reproductive health care, being trained up and recognizing the like signs that there might be a mental health concern as well. Then there's also thinking about service design and how we build that in. And I say that with caution because there's often a move towards universal screening that's not necessarily evidence-based or aligned with best practice. So you really need to look at the evidence, talk to the actual, co-design with people with lived experience, with people in that particular cultural context, talk to the clinicians and figure out what's the best way to do it. Building that notion into grassroots organizations. I mean, the good news is there's so much more that can be done because there's a lot of progress to be made in the area. But yeah, I mean, events like this and talking about it are certainly a fantastic way to get it on everyone's radar.
Thank you, Dr. Basu, for your response. Our next question is for Dr. Lishka. So I know you mentioned in your intro that your research at Yale looks closely at the history of anti-abortion in the US and Canada and like crisis pregnancy centers. So how do you see the false information being used to deliberately restrict access? And what tools can activists or policymakers use to push back against this misinformation?
Sure. Yes, so thanks. So I guess for people who don't know much about CPCs, just quickly, we talk about a crisis pregnancy center as a kind of anti-abortion pregnancy resource center. These are spaces that often offer things like free pregnancy testing, sometimes free ultrasounds, sometimes they'll have resource banks like diapers and formula and toys. To have access to the space, you'll often receive some education that includes anti-abortion talk points. The big problem here is that these centers are really not transparent about their goals. So very often they will advertise to people who are seeking abortion, who will go in thinking they are going to get an abortion and then receive strong anti-abortion messaging kind of at best. And then there are some more pernicious practices like stories about somebody misstating a pregnancy to push somebody over the line of when they can get an abortion. Or so those are some of the complicated things happening in CPCs. And I will, these are not just US based phenomena. It has become a dominant mode, unfortunately, of reproductive sort of healthcare, if you can call it that, in the States. But there are international outposts. A lot of them are parts of the activism work of US-based anti-abortion organizations that are going abroad as sort of mission work. So that's something I'm really interested in and would love to talk more about. I don't know that much about it yet. So in terms of what is happening in these CPCs and the kind of work that the false information is doing, I think maybe there are three kinds of ways to get at this. So one would be like what is happening inside the CPC. I see these as real activist centers, right? It's a place where pro-life women can connect with each other, advocate, can be more radicalized. These spaces are largely volunteer run, almost all by women volunteers. And I think in these spaces, a really clear kind of anti-abortion identity starts to solidify. So for one, it concretizes a mission, right? It lets people to do work that they understand as saving the most vulnerable kind of person. And we might think about what other kind of vulnerability that would overshadow. So CPCs start to grow historically in the 1970s, 1980s, which is the same moment when in the US we see things like a neoliberal turn, sort of right-wing governments who are pulling back on social services. We see things like the war on drugs, which is targeting Black Americans. We see a real impulse to blame people and not structures for poverty and for bad circumstances. But something that happens in the CPC is that like you can't blame a fetus, right? And so there's becomes this possibility to have the fetus as a moral center, something that might let a certain kind of activist off the hook for not caring about other kinds of inequality. And yeah, there's a vast amount of information that comes to defend that, right? Some of it really resembles what you might find in a medical textbook. Like some things are the same, right? Understanding the stages of fetal development, that isn't different, but what is different is the framing and how that gets mobilized to really create the idea of the fetus as that ultimate victim. And the women who work in these spaces become experts, right? They become experts in this kind of knowledge. They know these talking points. Sometimes women who had, and we just heard a little bit about mental health and reproduction. Sometimes people who had negative or ambivalent experiences about an abortion find a place in a CPC or in an anti-abortion movement where that can be acknowledged. They learn to think about that as trauma. Sometimes it is trauma. Sometimes they receive a very particular kind of framing, and that is a way of using information about trauma, using psychiatric discourse to enroll more people into anti-abortion activism. Another thing that I kind of alluded to when I was talking about this right-wing turn and safety nets is one of the reasons why CPCs have such a prominent place here in the US is because they offer free care and free services and things like diapers. So, of course, I feel like I have to say this care is very limited. It comes with really major strings. The costs are very high when, it's a pregnant 15-year-old who goes in and is looking for help and who cannot receive information. But also, there's something to be said that if there is nowhere else that somebody can go to get pregnancy tests or ultrasounds or diapers, the CPCs become a tempting kind of option. And so I think it's worth putting this into a broader conversation of both the goals and the effects of cutting the social safety net. It's not just people who are seeking abortion who use it, right? There's some really interesting historical work about pregnant people who intend to birth and raise children who go to CPCs and navigate that as a kind of resource in a system where they have access to so few other resources. So in some ways it feels a little bit trite, like a non-answer that like a solution here is making sure that people have access to the kind of comprehensive reproductive health care that would make those false promises, less tempting. Of course, that's not a simple solution at all. We all understand the many structural barriers to providing that care, but in some ways, these centers fit really tidily into a system that has gutted other and post Dobbs, right? That's even more acute when, some states now have no abortion clinics or one abortion clinic, and thinking about the kind of care that gets cut alongside that. Like if a Planned Parenthood loses all of its funding, then all of a sudden it has a much harder time doing breast cancer screening, has a much harder time providing contraception. And so I think for me, that is a core piece of the puzzle that isn't always talked about. Does that help to combat sort of false information, false narrative? I think that's in some ways a different problem that has to do with how we communicate science, how trust in science is now bifurcated along political lines in this country. So that's maybe a different conversation, something for the Q&A, but those are some initial thoughts that I have about this.
Thanks for your sharings, Dr. Likshay. And then next we have a question for Ms. Brukashin. I know you've led the UNICEF's global work on school wash and menstrual health across both development and emergency contexts. So, what lessons or challenges have shaped how you think about menstrual health as part of the broader reproductive rights conversation?
Thank you for the question, Karen, and thank you for trying to pronounce my last name, which is quite a challenge. So yeah, I would say the topic of menstrual health is an interesting one because it's very much interlinked with SRH and has a strong health focus, but goes beyond that as well. And I think this is also where the challenge comes in, but where opportunities lie. So the way that we think of menstrual health is that we need to address the different needs that menstruators have. That includes facilities to wash and change in a hygienic, private, safe way, the ability to access safe, affordable, hygienic materials that have good quality, that are their choice, access to information and education, but also have a supportive social environment where there's no stigma, no taboo, where we can talk about menstruation, about menstrual health. Menstruators can participate in social activities, education, work, etc. So all these aspects are important to meet the needs of menstruators. Now, how is that linked, for example, to SRH? There is a connection there, but SRH or SRH interventions are not the only solution. And I think this is where, yeah, like I said, this is a truly cross-sectoral issue where we need to bring different stakeholders together. So what we do in UNICEF, for example, we bring our health colleagues, we bring our gender colleagues, we bring the WASH colleagues, the education colleagues, all together, the social behavior change colleagues. And we look at what we can do together, what we can do for girls in schools to ensure they have access to a toilet that is menstrual friendly, that there is a bin, there is a mirror, there is access to water and soap, but that also that there are products in schools, that the girl has access to education and information, maybe a place to rest when she needs to. And this, I think, is an opportunity to have the connection with health and sexual reproductive health. For example, school programming and school health programming, the engagement of school nurses. What can school nurses do to provide correct information to girls about menstruation, and how do they link that to broader SRH education? Well screening in schools done by school nurses. How can we bring in the right questions about menstruation, and how can girls get informed? What if their period's late? What does it mean to get a period? What does it mean for her family planning opportunities, or what should she know if she doesn't want to get pregnant? So there's a lot of opportunities there. There's also risks. For example, there was a great article about school nurses and integrating menstrual health into education and SRH and into the information that school nurses, the work that school nurses do in the US. A great article that says, you know, in the US, a lot of parents actually have the option to opt out from education on sexual reproductive health. So if the only place where you include educational menstrual health is in that part of the curricula, many menstruators will not ever learn about menstrual health in school, which is really a missed opportunity. So we have to be very mindful that it is an opportunity, but it's not the only connection that is there, and it should not be. So we have to really look at the context. Does it make sense? How can we link, and where are the other opportunities to also talk about menstrual health? Because this is, it's also an entry point. Maybe we talk about menstrual health, but we can talk about other things as well that maybe are more controversial. And so it goes two ways. Menstrual health people, programmers, they want to use SRH as an opportunity to talk about menstrual health, but at the same time, for the SRH world, it's an opportunity to talk about things that are important to them that go beyond menstrual health. A great example, UNICEF has an app. It's called the OKI app. It's a period tracker for girls. It's designed in consultation with girls, for girls. And it's a very contextualized, local app that protects the privacy of girls. It can be used without internet. It's very simple. It's a gamified app. And this app, it's a period tracker app, but it has so much more information about puberty, changes in the body. What does it mean to get your period? What is normal? What is not normal? And so it's an entry point. It's a safe and less stigmatized or less scary entry point to talk about other issues that these days we may not be able to talk about as much as we would like to. So that's an opportunity how these two sectors could collaborate and could collaborate closer to say that there is full integration between menstrual health and menstrual health interventions and SRH. It's not yet there. The opportunities are there. For example, the improving education and awareness from both sides in menstrual health education and awareness. We can connect to SRH and vice versa, but also connecting better with health systems and health services. For example, already what I mentioned in the schools, through school nurses, well screenings in schools, but also around counseling on family planning. How do we ensure that the right information on menstrual health is available there? How can we ensure that especially girls can get diagnosed if they are dealing with menstrual disorders or pain? What are the options for them, maybe accessing contraceptives or other ways to managing disorders? And how can we get girls diagnosed sooner if they suffer from issues like endometriosis, which is often takes 7 to 10 years to get diagnosed. So these are all important issues that we can work closer on. And definitely, I feel a little bit of an outsider here in this forum because I work on a very niche topic, and I work actually on a topic from the WASH field. But it's a great opportunity for me to learn much more on SRH and also try and build these bridges with other sectors that I don't engage with that much. And I'll close just by saying that I've heard many of the speakers talk about CSW. It's a great opportunity to also position menstrual health as an important topic to be addressed. And together with the Global Menstrual Collective, we developed an overview of the different connections between menstrual health and the Beijing Declaration and all the different priorities that are listed there, and it includes SRH. So I'm going to put the link to that document in the chat so that everyone also has an idea of, how can we work in a more cross-sectoral and collaborative manner on this topic and learn from each other and benefit from each other's work. Thank you.
Thank you for such a thoughtful response and for sharing more about your very important work. My next question is to Dr. He. Dr. He, you've worked at the intersection of youth health education and reproductive care for over a decade. What do you see as the most powerful ways young people can shape sexual and reproductive health systems, both in policy and practice?
Okay, thank you, Jessica. I believe this issue can be reframed as how can youth reshape the sexual and reproductive health system. I will address this question from several perspectives. Youth need both medical expertise and social mobilization skills to drive systemic change. So the key to youth participation in policy reform lies in translation right-based discourse into accessible professional narratives. So our strategies, first one is data-driven policy proposals. The China Family Planning Association and Tsinghua University conduct nationwide surveys on college students' sexual health every 5 years. So the 2019 to 2020 survey engaged nearly 60,000 students from over 1,700 universities. Evidence-based youth advocacy gains policymakers' ears. So a new round of surveys has just launched. I will looking forward to see this result. And the second is we need to communicate through a youth-centric approach. China low, for example, China low fertility rate has become a major social concern. But if we directly urging youth to reproduce triggers resistance. If we shout, hey, you go make babies for the country, wow, they will run. So we need swap our lectures for maybe a TikTok style checks. When we talk about relationship first, then slide into marriages, finally reproductive health, they will accept what we see. And it's important to talk to young people in a way that they like. And last year we have an exchange program. We invited the youth from Mongolia and Kenya. Their youth come to China, and the Kenya youth they said they are recycling waste into sex education tools. I was so impressed by this. So in China, we also have a slogan called "by use for use." I think it's very important. Yeah. So the third one maybe I will say we need a campus to a career pipeline. Yeah. Our youth leaders always say they have a faith that they are not temporary volunteers, but lifelong devoters. So we need a career pathway design. Many university trainers discontinue sexual education after graduation due to due to due to some gaps. We now felicitate dual track placement. We will recommend them to local institutions while supporting others to some SRHR perspective into fields like public safety, such as sexual violence or prevention of HIV or some digital media. Not only doctors or teachers can do this job. I think everyone can do this job if they have strong willing to. Yeah. So the next is digital tool development. Yeah. The use is not only the user, but also co-creator of tech solution. Many AI sex education apps I found they have harmful stereotypes through biased training data. So we are implementing an active content intervention to counteract dangerous narratives such as domino effect. What is domino effect? If you are dating with someone, you will have sex. If you have sex, you will be pregnant. If you have pregnancy, you will be get a abortion, and your life will be ruined. So it's totally disaster. It's totally mistake. So we will do something to stop this stereotype in AI education apps. So the use design is significant to ensure young people to help them establish digital platform rules rather than just consume content. Okay. 13 years ago, I founded Hangzhou Youth Network as a medical student. I just want to eat through all campus cafeterias. Today, we've helped 42 universities setting sex education courses in Hangzhou, while our National Youth Network team guide programs in over 600 universities nationwide. So one guaranteed real decision-making power. Youth don't just solve problems; they redefine what youth needs mean. Okay, that's what I want to say.
Thank you, Dr. He. I saw a question in the chat box. Anyone want to answer? Says reproductive rights without accessibility is structural violence. How are global systems ensuring that rural, indigenous, and marginalized women are not just included, but prioritized in funding, policy, and accountability frameworks.
Oh, okay, it's a question for me.
I
Open
guess.
for anyone.
Anyone.
Open to,
It would
yeah,
like to
anyone
answer
who
Oh,
this.
would
okay.
like to speak on it.
I can talk a little bit about it, maybe more from the menstrual health angle, but I guess it has lessons for the SRH part of the work as well. So in addition to the what I had explained earlier of how we address menstrual needs, there is an entire area of enabling environment, strengthening enabling environment, which is what we also work on. So that means working with government stakeholders to ensure the right policies, plans are in place, that there is enough data and evidence to inform these policies and plans, to develop, ideally together with government, costed roadmaps, to implement programs, and also to organize coordination between different stakeholders. Thinking of menstrual health, you'll have to include the Ministry of Health, maybe there's a Ministry of Women and Gender, maybe there's a Ministry of Education, maybe there's a Ministry of Water or Sanitation that you want to engage with as well. So there's different stakeholders that need to kind of sign up for a policy and a plan that you then want to implement. So all this is very important to work on, and it should be led by the government. I think that is really the key, because you want to leverage government investment in these programming. And if you and we shouldn't just talk about women and girls, we should really talk about menstruators, those who menstruate. So that is often the challenge, because a lot of these programs then are only for women and girls and not for all others who menstruate. So that is some of the challenges that we face. And also making sure that everyone is reached, including indigenous, rural, most marginalized. That's another challenge. But there are programs that directly directed to these more marginalized groups that you could piggyback on, so to say. For example, there are programs that provide menstrual materials in schools for girls or for menstruators who cannot afford otherwise. So that's a clear way to reach girls in rural marginalized communities who otherwise would not be able to have access to this type of products and would probably not be able to go to school during their period, right? So it's a very clear example. And having the data to direct that government investment to those who need it the most is really crucial. So you need to bring the data, the evidence, and then make the case why these are the people who need the investment the most. Thank you.
I noticed someone raised their hand. Dr. Nadanobi.
Thank you so much. If I may, I find this a very relevant question for this session. And, indeed, it is structural violence. For those who find it difficult, I spoke of access as I made my remarks at the beginning, because sometimes the assumption, and thank you, Marika, for drawing our attention using the lens of menstrual health. The assumption is that, these girls can easily access school or easily access healthcare. But we have to think of the rural areas where, girls are out of school, menstruators are out of school, but especially girls, because girl child education is, still culturally behind. So if we talk about, for example, using apps, it's not applicable to everyone, because there are rural areas where there's no data, where there's no connectivity, the road infrastructure So when we talk about a cross-sectoral or collaborative approach, it has to be an all of government and all of society approach. And we need to include other sectors of the government, like the Ministry for Roads and Transport. You know, we need to look at, as I said, connectivity, and work with those for whom there is utmost trust. And that's why when I, said we need to look at not just the reproductive parts of a woman or girl, but to look at her, not just the sum of the reproductive parts, but to look at her as human in her entirety. Why do I say that? Because you need to look at the social. Ashna spoke eloquently about stigma, shame, and silence. Who are the people that they trust? They trust their spiritual leaders in some places. And we need to look at humans also as spiritual beings. Who are the religious leaders? We should not shy away from speaking about faith. Who are the faith leaders? Let's not shy away from talking about traditional leaders. When Ashna spoke, she said, she's speaking from the Australian culture around, in the indigenous, paying respect to the indigenous owners of the land. So we need to learn to work with these people. Sometimes we're focused a lot on AI, on modern technology, on apps, but we also need to look at the vertical as well as the horizontal. Thank you very much.
Thank you all for this very rich and energizing conversation. We actually had so many more questions prepared, and I'm sure the audience would have had a lot. But I realized that in respect for everyone's time, we were also originally planning to move into breakout rooms now. But again, in the interest of time and out of respect for everyone's schedule, we're going to move straight into our closing remarks. Thank you so much to every speaker, participant, and partner who made this event possible. From reproductive health to gender equity to economic justice, what we heard today is that these issues are not separate. They're deeply interconnected. And at Choice for Tomorrow, we believe youth leadership isn't just valuable, it's essential. So whether you're a high school student organizing on campus, a doctor reshaping clinical care, or a policymaker pushing for global change, we all play a role in turning rights into reality wherever we are in this world. Today reminded us that access is everything, because without access, rights are just promises on paper. And more than anything, today reminded me that we're not alone. We are building something across borders and across generations with care, urgency, and vision.
I couldn't agree more. On behalf of Youth Help Youth, I want to thank everyone who made space and time for truth, hope, and action today. Reproductive freedom isn't just a personal issue, it's a public one. And if we want systems to change, we need to be at the table. This is why spaces like this matter. They make room for policy rooted in lived experience and leadership that's not just top down, but peer driven. We hope you'll stay connected and continue these conversations in your own communities. Join us in building a future where no one is denied care, dignity, or choice because of who they are or where they live. Thank you for being here. This is just the beginning.
And for people who are willing to stay behind for the breakout rooms, we decided that we will host it because we do have moderators for that. So if anyone is interested or has the time to stay behind, we'll be discussing the Sustainable Development Goals, develop a youth-led policy recommendation, and we will be reporting this back to the UN in part of the ECOSOC event afterwards. But to be mindful of everyone's time, this is the official end of our session.